And now we're moving into the Q&A part of the webinar. Please enter your questions in the chat box. Moderating the Q&A will be Deb Walkenheim, so you'll hear her voice. I'm not sure if she's on video. She's the Assistant Director of Research Dissemination for OpenNotes. And while you're inputting questions, I just want to mention a few things. When we have some more webinars coming up in the next 2 months, we have a link to that. It will go in the chat box. But pay attention, Thursday, February 18th, we're doing OpenNotes in pediatrics and with adolescents. And then on March 8th, we're talking about open oncology notes. And then on March 23rd, we're exploring open inpatient notes. So this is going to be exciting in the next few months. After Q&A, if you stick around beyond the hour, Dr. Lin will be here playing his hit song about OpenNotes on the ukulele. So stick around for that. You might hear about it TikTok. And then all of our folks, the presenters here are on video, so this is great. And we're going to open it up to Q&A now. So Deb, what do we got in the chat box?
Hi, so I know you touched on this to some degree, but a couple of people asked any thoughts on how to write mental health open notes in particular. So anything you want to add to what you've already shared?
So I'm happy to start, and CT and Kate and Liz jump in. First of all, I want to say that the webinar by Stephen O'Neill and Dr. Dobsha is incredibly helpful, and I really highly advise you to look at that. I think, and I'm not going to quote them as well as they say it, but basically, I think trying to say things, as I said, as you would in the office. I think if you explain the diagnosis and your feeling about that, and then you discuss that with the patient, and then you basically document what the patient is saying and how they reacted to that and what their thoughts are and what your thoughts are about it, it's still okay not to agree as long as you outline it respectfully. I think there are rare situations when a patient is extremely paranoid that sometimes word choice, you want to be careful. And I think, for instance, the word agitated has come up a few times. I don't think it's the most, it's a word that can sometimes be triggering for some patients as a negative descriptor. So I think it's better to just describe what you're seeing rather than the summary being agitated. I don't know if CT or Liz or Kate, whether you want to add to that, but essentially we have found it is very positive and patients want to see this, benefit from seeing it, and actually think more about the therapy, et cetera, because of it.
I'll say that at UC Health, our depression center, our faculty, and our faculty resident practice in psychiatry have been OpenNotes for about 3 years now, thanks to the leadership of those practices. And they've had essentially no concerns after having gone forward. They feel like if you're having transparent conversations in the room with the patient, there's essentially nothing that surprises them in the progress note. So the opposite caution would be not to write things in the progress note that you really haven't already discussed with the patient. And word choice does become a concern for those who are particularly paranoid and so forth. But that the partnership description of where we're going, in terms of empathy and teamwork can be incredibly powerful. And that's what we found in our organization. In fact, the read rates of the patients in those psychiatry practices is actually slightly higher than in our medical practices. And again, they've had no challenges with that in the last 3 years.
Okay. A question, obesity seems very tricky when we have to code correctly. Any advice to teach the patient that this is for billing and not judgmental? And then there was another related question, another related question someone else had for something like morbid obesity. Isn't there a thin line between wording it nicely and sidestepping the severity and medical risks of the condition? Perhaps it's useful for the patient to see the word morbid.
That's a really good question. I have gone towards the use of severe is what the terminology that is more advised rather than morbid. You could make the argument that lots of things are morbid. Congestive heart failure is morbid. High lipids are morbid. And it's an interesting development that we only use it, and it tends to end up having a labeling effect. And so most people, there's a really good article in the literature about weight and weight management to go away from that and instead just do BMI as well as gradations of obesity. Does not mean, and it's a complicated subject, it does not mean that obesity does not exist as a medical condition or a subject. That should be part of the conversation with our patients and therefore needs to be a part of the conversation in our documentation.
I'll just make one brief addendum to that. Thank you, Leonora. That if you link, and it's the unusual patient who will not have linked diagnoses. So when you link the obesity to osteoarthritis, obesity to the severity of the diabetes, sometimes that link is not as obvious to the patient, making that explicit. The reason we're interested in the obesity is because of its impact on your other conditions. That's why we consider it together. That can be quite empowering for patients, I think, or get this aha. We've had several clinicians say, when I was actually able to speak about them together, they go, oh, that means they go together? And yes, this is the reason why we talk about it.
I would just add that there's so much literature about enormous bias in the medical profession, and not just doctors, but the whole care team around obesity. And we know that there is implicit bias there, and it gets reflected in our notes. And so I think it's a very complex subject. There's a lot of work to be done in this area in order to empower patients that what they're feeling is not our judgment, but our teamwork. And I think there's a space there for good articles to be written and advice to be given to the health system.
How do you document discussions with multiple family members who have asked or expected you to not share their concerns with others or with the patient? I am thinking about end-of-life decision-making, different parent-patient opinions about transitioning to palliative care with teen oncology patients, etc.
CT, do you want to take that? I feel like I need to read that to see it better.
Yeah,
is it showing up to us?
Yeah, I'll say that this is a challenging area for us. Our palliative care service does have, I think, a required statement called the surprise statement, which is, would you be surprised if this patient were to die in the next 6 months? And oftentimes that doesn't come up in the conversation, but it is a required part of documentation for palliative care. And when patients see that in the note, that's a surprise to the patient, in addition to being the documentation of the surprise question. And these are issues that we've not completely resolved. We are still working through how do we introduce this idea to the patient. It's important to the palliative care specialty to be thinking about this, but can we back this up to make sure it's part of the actual conversation so that it's not something you go home and read about and go, really? They didn't say anything about this in the visit. So that's the disconnect, and these are some of the touchy issues that we do have to be very thoughtful about.
And I'm sorry because I couldn't hear the question fully, but was there something about when some family members don't want that to be known? If there's that element too, I think it depends on the scenario. So in terms of who's reading the note and who's making that possibility for the note to be read. So sometimes I have patients who, because we don't have a formal care partner portal access, the patient is actually accessing the notes through the patient's permission, but under their name. And so you may be referring to that sort of situation. And I think that there needs to be a conversation when that occurs as to what that will mean. And then a sort of a conversation about what we call deferred autonomy or not with the actual patient. So asking the patient, you know, things will come up in your chart regarding your care. Do you want me, one, to be discussing some of the details with your loved one? Is that something you would prefer that way? We have patients who have deferred autonomy who will say to me, I don't want to know all of the details, such as what your timeline is, but I do feel okay with you talking to my relative about that. So I think it's all an issue of just having a conversation about how you want this discussed.
You have recommendations for documenting unanticipated outcomes.
Do you mean like errors, or more like low probability events that occur? But I'm wondering because they're slightly different. So I think that gets into the whole field of how we share errors with our patients. So if it's about the former, I think there's increasing thought that transparency is best. But there's also thought that sometimes you need to sort of process a little bit with others how to do that best and whether there is an error or not, or what. So you basically tell people what you know at the moment of what you have found it out. But I don't think you basically initially call it an error, neither in the document nor in your conversation, because sometimes it takes a while to do the root cause analysis to really understand what has occurred. But essentially, a long-winded way of saying transparency is best. And if there's an unanticipated finding, I say this is really unexpected, and how are you doing with this? And also my teamwork that I plan to look into this more with them. I don't know, CT, thoughts on this?
So I think it depends on what the questioner was asking, but I'll take the other half of that question, which is what happens if you have an unanticipated test result, or this particular symptom actually evolves into something that none of you were really expecting. One of our neurosurgeons actually had a nice paragraph for us as we were looking at not only OpenNotes but test results, the idea that I'm going to do a CAT scan, and this is on a patient who might end up having metastases to the brain, for example, and we were very worried that we currently had up until November a 7-day delay on CT scans being released to the patient, because we wanted that week for clinicians to be able to absorb the information, go consult with their physicians, and then call the patient and say, this is our team plan. And now this is being released immediately, and we had a big uproar about how are we going to possibly survive this. And our neurosurgeon stepped up and said, I've been releasing test results immediately for years, and it's not a problem. Here's why. And that's because I do take the time to say, I'm going to do a CAT scan on you. Here's the worst thing that could be. It could be multiple metastases to the brain. This is what that means. It's incredibly unlikely, but that's possible. It could also be this, it could also be this, and I'm expecting it to be normal, right? And you back your way into what you expect, but you do mention that this is how we handle the test result. It may take me 2 days. You're going to see the result before I do, but it may take me 2 days to get with you. Please don't call in a panic expecting that you have to interpret this yourself. I'm here with you. We're going to work on this together. And, that 15-second, 30-second conversation can be quite relieving to the patient when they go and see that result online for the first time. And so it does take a shift in thinking. So I'll stop there.
Oh, you were at a pause, and I was like, oh my gosh, we have 1 minute left, and we need to thank everyone for being here. Thank you so much for signing up for the webinar. By the way, I put in the chat box, Dr. Lin and Dr. Fernandez are going to be available next Tuesday to answer any questions you have about documentation in the age of transparency and OpenNotes for a full hour. Please sign up. Everyone will be on webcams, and you can just ask straight up. We shared the link in the chat box, like I said. Again, as a reminder, this webinar was recorded. Since you signed up, you will receive an email, hopefully in about a week, with a link to it and the slides. So everyone gets the slides. And I think that's it. I want to thank everyone who showed up and registered to be here today, and especially thank our extra special presenters, Dr. Leonor Fernandez, Dr. CT Lin. Kate's my boss, so she's around here all the time. But thank you, Kate, for doing that great intro presentation. And many of you have to go back to work and your lives, but I did want to say stick around because CT Lin has written a song about OpenNotes. And so this is, we're going to end out the next few minutes. He's going to pull up his ukulele and we're going to have a fun time, which is the coolest way to end a webinar ever. So thank you all.
Thank you. Thank you, Liz.
Thank you.
Thank you.
All right. Those of you who have heard me sing know that I don't know how to sing, so my apologies ahead of time. And it's your fault that you stuck around. So this is what it is. This song is called Doc Prudence, and you may have heard the melody before if I actually get close to the melody. Doc Prudence, won't you come explain? Doc Prudence, can you tell me again? The words you write, I have no clue. Why put it away? Why hide it from view? Doc Prudence, won't you tell me again? Doc Prudence, let the patients read. Doc Prudence, you just might succeed. Your words will be a ray of light, so let us see all of your insights. Doc Prudence, won't you let the patients read? Doc Prudence, you've opened up your notes. Doc Prudence, I can even see deoxyribose. The words you write, I can Google too. You're sharing with me, but you're still my guru. Doc Prudence, you made me a partner with what you wrote.
Wonderful job. I have to say the number of attentive attendees has gone up during the song. So thank you everyone who stuck around. And I got an alert on my Apple Watch that my doctor's notes are available in my patient portal right now. So what a perfect way to end the whole webinar. I'm going to go read those and thank you for everyone who's attended today. Take care.